today my topic is about suffering in MND. So I'm going to start my sharing. Okay, so today we are going to talk about suffering. And first of all, suffering is a state of undergoing pain, distress, or hardship according to the Oxford Dictionary. And you have to remember the famous statement by Eric Cassell: suffering is experienced by person. And a person, you can divide it into multiple dimensions: physical, psychological, social, and spiritual. So in managing suffering, it is very important for us to ask, who is this person? When we look at the patient, we not only focus on the disease or the pathology, we have to understand who is this person beyond the disease. So I'll give you an example, like if you ask, who is this person? This is me. And then a person has a body. And then the mind, as you can see. And a person has a family. And this is my hometown in Beng. And my work with the medical student. And of course, the most important one is my religion, which I have many religions. One of it is food. So food is very important to me. It has a lot of meaning to me. So when we treat a disease, we may win or we may lose. But if you treat a person according to Patch Adams, we will win no matter what the outcome. So in managing suffering, my first key message is treat the person, not just the disease. So suffering in patients with MND. MND is a motor neuron disease. You can see all the problems arise from the problem with the motor neuron. And motor means movement. And movement means activities. All activities you are doing now or you are doing before that, they are all movement and they are all relying on your motor neuron. So all these like movement rely on the motor neuron. So the first suffering that the patients with motor neuron disease will experience is we'll go through one by one the dimension. So we start with physical suffering. The main suffering of patients with motor neuron disease is loss of function because of the degeneration of their motor neuron. So one of the function is like simple things, cannot hold a cup, especially if they start with the limb onset. Or maybe if it's a lower limb onset, they can trip and fall. And when the disease advances, it may affect more parts of the body, and like patients may have difficulty to walk. And eventually the bulbar muscle can be affected, or even on the onset, if it's a bulbar onset. And then maybe having difficulty to swallow food. Yeah, as you see, food, I mean, to me is my religion. So if the moment I cannot swallow food, there will be a lot of suffering. And even cannot breathe. I think breathing for me also is very important. So the moment cannot breathe is going to be suffering. So at the end, some patients can move their eyes only. It's just like lock in like that. Can only use eye movement. Yeah. So these are the physical suffering caused by loss of function that the patients are going to face. And of course, there's some disease-directed treatment to delay the progression of the disease, such as Riluzole and edaravone. But the evidence is like not strong enough. We still need a lot more medication to help with the disease. And there are many technologies now to replace the loss of function, such as the eye tracker, the electrical wheelchair, the EEG computer brain interface, the cough assist, the speech synthesizer to replace the speech, and the PEG for the feeding, and NIV for the breathing. So all this technology can be useful to replace the function that's lost due to motor neuron disease. And those technology cannot be replaced by the family caregivers, because when you lost a function, you need to depend on others. The person that you need to depend immediately is your family member. So your family member play an absolutely important role in providing the function that you have lost together with the technology. So these are the physical suffering due to loss of function. We'll go on to physical suffering due to physical symptoms. What are the physical symptoms that the patients with motor neuron disease may experience? So it depends on whether it's starting from the limb or starting from the bulbar area. So you will have all these symptoms like siluria, pseudobulbar effect, like you just cry suddenly, or you laugh suddenly. I mean, some of my friends have this pseudobulbar effect. Suddenly they just cry like that, or suddenly laugh or shout. And spasticity, you can have spasticity, cognitive impairment, and so on. So these are the common symptoms. And of course, to reduce their suffering, symptomatic management is as important or more important than the disease-directed treatment. These are some of the examples to manage the symptoms. However, I won't go into details because all this will be taught in a future webinar series. I just want to mention two symptoms. One is cough. So when the cough is very weak, you can learn some simple techniques like breath stacking by inhaling before you try to cough out. So it's like gathering the volume of your inhalation before you cough out. And you can have assisted breath stacking using a lung volume recruitment bag to increase the inhalation volume. Or you can even use a cough assist machine, but this is very expensive. The second very common or prevalent symptoms in MND is fatigue. And if you ask a patient, they may describe two forms of fatigue. One is a whole body tiredness, just feel tired and no energy to do things. The other one is reversible muscle weakness. They are more focal. It's like very localized weakness and feeling weak after doing certain things. Yeah. So this fatigue can be even with simple things like dressing. It will take a lot of time to dress, or cooking. Last time can cook, now probably cannot cook, can only give instruction, or read newspaper, read book. All these simple things like this need even stand up, eating, or even moving a mouse. And you want to move a mouse, but it will take a lot of energy, and after that you feel very fatigued. So these are some of the symptoms that may be experienced by our patients. However, watch TV somehow is okay for many, especially if they're watching without like changing the channel, because changing channel you need to press the controller. So you just watch whatever movie come to the TV, just like when we practice mindfulness of our mind, we just watch whatever thoughts that come and go in our mind. Somehow watching TV is okay because the eye movement usually is bad. They can just move their eyes to watch the TV, or even some people no need to move their eyes at all. But it takes energy also for them to watch TV, and need energy to socialize also. You have to decide whether you want to entertain the friends or not that come. Most people, of course, they want to give the energy to the friends, but they must understand after they speak to their friend or chit chat or listening, they may feel very tired after that. So they need energy to socialize. And they need to recharge themselves because they feel tired easily. So before an activity, they need to recharge by resting prophylactically. Then after that, they can eat. After that, they probably need to recharge again. So it's like very little energy. And some people recharge by having an NIV, then they feel very tired in the activities. After they use the NIV and then they got more energy, then they can do things again, but not everyone. So what we can do to help them, one of it is all those mindfulness exercises. Conventional one takes a long time and a lot of energy. Patient may not be able to practice it. So you have to focus on very short or brief mindfulness practice, as short as possible, and tailor it to the activities of the patient. For example, they can do budgeting before they perform any activities. Like in this case, it's drinking coffee. So you have to think of to drink or not to drink, to do or not to do, not to be or not to be. So they have to think. If they want to drink, okay, they need this energy, and the energy is maybe you need three-star energy out of 5. So okay, I decided to drink. Then you can teach them to like practice mindful breathing to recharge for a few seconds, a few minutes. After that, they can start to break down the activities into multiple mini steps, and they can also do mental noting while they are drinking. For example, leaving the cup and then sipping the coffee and swallowing it. So break them into mini steps and just note like leave in their mind, and then sip, 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 swallow, swallow, swallow. So especially if there's a lot of distraction or a lot of automatic negative reaction or thoughts in the mind. After that, then you can guide them to practice mindful breathing again to recharge. So this apply to all simple activities. And in practicing mindfulness of activities, there are 4 ingredients: making effort, being mindful. And that is not enough. You also need to see the nature of things clearly. And with that, you'll be able to remove all the automatic negative reactions. That means if you are drinking coffee mindfully, at the end of the day, you should feel happier and there's no more stress or negative thoughts. So if you are not doing it mindfully, then you will still have a lot of stress after drinking the coffee. So even simple things like breathing or moving the fingers, if you do it mindfully, you will feel happier after that. So of course, some evidence, this is the only evidence right now. Panini did a study on mindfulness in MND patients. The RCT showed that mindfulness versus usual care for 8 weeks, it reduced anxiety, depression, negative emotion, and improved interaction of patients with the family member and the healthcare provider, and also the environment. Okay, we'll move on to psychological suffering. So there's a lot of psychological reactions that come together with the loss of function and the depending on the family member. And to understand the reactions, we can look at the MND trajectory. The MND trajectory is different from the cancer trajectory or the frailty or the sudden death or the sine waving trajectory of the organ failures. It started with a phase 1 where there is a lot of time spent in making a diagnosis, up to even 1 year. So then there's a lot of psychological reaction due to the delayed diagnosis, because you can be angry or unhappy, frustrated. Why I need to go through so many tests? Why I need to see so many doctors? So if you can shorten this diagnosis time, you have more awareness, you see the neurology straight away, then maybe the diagnosis time will be shorter. And then after that, they have a phase 2 where they already found the diagnosis and they start to experience the loss of function. So there may be a lot of reaction due to the loss of function, such as like shock, why you got the disease, all this denial, anger, or depressed. And there are 4 to 12% of patients with MND, they experience depression, and even for those without depression, 25% got this the desire to die when they are functional, they have functional loss. And the last phase is the psychological suffering due to uncertainty. There's a lot of uncertainty. You do not know how long the terminal phase. It can be longer. You can see that the graph is not touching like the cancer trajectory touching 0, but it's like asymptotic graph. So it's like as long as you give some technology, you may be able to like prolong the life. So you do not know by treating the infection whether the patient life will be prolonged or not. A lot of ambiguity about chronicity and terminality. So people call it the unstable terminality. So if you can make the patients aware of this uncertainty, maybe they may be more prepared. So look at all the suffering and the psychological reaction, you know already, palliative care should be involved at the time of diagnosis. This is what happened in our center. At the time of diagnosis, palliative care already sit in the clinic. And it has been shown that palliative care improve MND quality of life, especially for the physical symptoms. One will be pain, dyspnea, sleep, and constipation. I didn't mention the psychosocial part. There's also evidence. So psychosocial care for psychological suffering, the emotional reactions. Many people think of a lot of psychotherapy, but I must stress that one of the most important psychosocial care is just give medical information. Give them the proper medical information sensitively about the diagnosis and the prognosis, followed by giving them hope. And that is already very useful for them, including the uncertainty. And there are studies who show that if you give 2 appointments 14 days apart after breaking the bad news, the patient is better able to cope with the diagnosis. And no need to know a lot of psychotherapy, just listen to the patients and their experience and allow them to express their emotion rather than asking them not to cry or not to worry or not to fear. And then advanced care planning, clear contact point for advice or support if you can. Give them a phone number to contact and see them every 2 to 3 months according to the NICE guideline. You can see even like earlier if their patient got problem. So before we can plan for the patient advanced care plan, we need to know a bit about the prognosis of motor neuron disease. Most of them survive for 2 to 3 years, but some they will be alive at 5 or 10 years. And the prognosis varies with age. Older age poorer prognosis. Bulbar onset, poorer prognosis. If you stay in the mountain area, poorer prognosis, maybe less access to the technology or the healthcare. And occupation, farmer, also poorer prognosis. Cognitive impairment, if you have cognitive impairment, also poorer prognosis. And you can calculate the prognosis by calculating the functional rating scale of MND patient. Basically, is you score the daily activities like speech, salivation, swallowing, etc. from 0 to 4 and see whether they have loss of function or not. So after that, you can divide them by the duration at the test date to find out the progression of the loss of function. How fast the loss of function occur. If very fast, then the survival will be shorter. Then you can put in the RLS progression, LS, FRS progression, together with the onset of the disease and also the cognitive impairment or executive dysfunction and come out with the total LS prognostic index to find out what's the roughly estimated survival. So with this, it will help you in your advanced care planning, but the way you communicate all this is a completely different story. So remember, to reduce their psychological suffering, early SCP is needed. Prepare the patient, talk about the gastrointestinal issues, and talk about their respiratory issues. So like PAG, PRG, PIG, and for respiratory, usually it's NIV. NIV got survival benefit, especially you start early and like we'll prepare them early. And very rarely you will need to go for tracheostomy, but of course you need to discuss it as well. And you need to discuss the withdrawal of NIV as well with them just to prepare them in a very sensitive manner. Some of the suffering experienced by patients with NIV, we have to be mindful of all these NIV related suffering. So what about psychological suffering in terms of cognitive impairment? Patient can experience frontal temporal dementia, 15% of them, and they have ALS-BI, the behavioral impairment that acts like a baby, and ALS cognitive impairment, like they have problem in like solving problem in solving problem. Yeah. So some of the example of behavioral impairment, I remember it by using an example of Mr. Bean, like there may be self-centeredness, irritability, apathy, emotional blunting, loss of embarrassment, disinhibition, of concern for themselves. This one not so much for Mr. Bean, and reduced empathy. So these are you can remember all this when you think about Mr. Bean. Yeah. And the clinical implications of the cognitive suffering is we need to screen the cognitive impairment very early. We need to do early advanced care planning before they lose their cognitive function. And we need to support the caregiver tremendously because once they lost their cognitive impairment, they are more stressed for the caregivers. And also need to limit decisions to 2 clear options only when cognitive impairment is a problem for the patient. And to assess caregiver needs or caregiver suffering, we need to find out which domains or what are the items that the caregiver is suffering. We need to support the caregiver. So now the social suffering, the family stress, the caregiver can experience stress from immediate care work, you need to like replace all the function of the patient that's lost. And you need to find out information about the disease and prognosis and managing competing obligation. You have to take care of patient and you have to work as well for some. And you have to struggle to maintain the normality. It's like your life is no longer normal. You've given all your time and energy to take care of the patients. And you need to also find out the resources and the support that are available and you mobilize it. So often, a lot of studies show that the caregiver quality of life, they are less than the patient quality of life. So to support them, we need to have a multidisciplinary team, and it has been shown to increase survival benefit of patients for around 8 months. So the multidisciplinary team, you have a neurologist to take care of the motor neuron, and you have the rehabilitation team to help them to deal with their loss of function. And you have the gastrointestinal team to support their nutrition, and the respiratory team or intensivists to like give advice on the respiratory support. And of course, the palliative care team to improve their quality of life, and it will involve the volunteer. And of course, having a non-profit organization like MND Malaysia will be very helpful. They can provide a lot of information and support, very precious information and support for patients and their family member. So finally, the last domain is about spiritual suffering. There are a lot of spiritual suffering in MND, like such as why me or spiritual, religious related issues or whatever, but I will focus on death and dying only. So for MND patients, I have to like say that the way they die is the dissolution of the earth element occur very fast. Is the earth element means they are the solid component of their body, the function. So it's like it happens very fast. It's like they are experiencing dying very, very early in terms of dissolution of the earth element as described in the Tibetan book of death. And when it happens, there are many, many symptoms that the patients will experience. Oliver did a study on the prevalence of these symptoms at the end of life. You can see all those, there are a lot of symptoms are more than 50%. So it's very prevalent. There's a lot of suffering at the terminal phase. That's why you need a team to like provide a lot of symptom control and support for the patients at the end of life. And one thing that can complicate the decision whether the patient is at the end of life or whether there's a reversible infection or not is caused by this discrepancy in clinical death and the autopsy. In clinical death, the cause of death, they write as hypoxia, most common. But in the autopsy, a lot of time it's a pneumonia. Hypoxia is only 3%. That means pneumonia, some of them can be treated. So how long you want to treat and how many bouts of infection you want to treat, all this, with the advanced care planning, it can help to make the decision. And one must know there's a myth that MND patient that will choke to death, but it is very rare for patient to choke to death. Choke to death usually happens for those with a large airway problem, large airway blocking. But majority of patients die peacefully, 88%. And for those who are not peaceful, they can be helped. Their symptoms can be relieved by very simple interventions from the palliative care team. So it's important to know that and reassure the patient. Most of the patients with MND is very peaceful. And to help them to relieve their suffering at the end of life, apart from providing them with a symptomatic management, spiritual care in terms of being here for the patient, helping patient to come back to the present moment, the here and now is very useful. The only study that I mentioned this is from the rabbit psychological and psychotherapeutic approach for people with motor neuron disease. They interview all the healthcare providers. The healthcare providers say the most important intervention and useful one is to help patients to focus on the here and now. And at the same time, they themselves have to be completely in the here and now. And if you want to learn how to be here and now, this is a highly recommended book from Thich Nhat Hanh about true love. The first chapter help you to be completely there for patients and free of all your judgment and your preoccupation, your preconception, and your thoughts about lunch later. All this they're able to like be there completely for the patients. Then of course you can also get this book from the Amazon, mindfulness book, how to be fully present for others. That's very important for the care of MND patients, and it's written by Dr. Me and my ex-medical student, Dr. Tong. And of course, you can subscribe my YouTube channel and help me to grow the subscriber, and of course, can like this as well. They are very short practices designed specifically for palliative care patients. And with this, I want to say thank you to everyone for listening to my sharing.